So, ladies and gentlemen, good morning, good lunchtime. My name is Jean-Charles Prézère. I'm from Brussels, and I would like to welcome you to the symposium, to the ISICEM first, and second, to this symposium organized by Nestlé Health Science on the challenge on the road to personalized nutrition. I think that indeed nutrition in the ICU and after the ICU are coming really a very hot topic. It's really exciting times. We have seen that many large studies were performed and published, including the Nutria 3 from France, published this morning in the Lancet Respiratory Medicine. It's a moving field, as you know, that the challenges, there are many challenges, and our previous ideas and thoughts were hardly challenged by the new data. We are coming also with more evidence-based recommendation. The doctor designed after the publication of these studies in major journals. Also, the effort trial from Heiland and co-workers was also published in the Lancet earlier this year, and this is another piece in our mind to improve the nutritional care of the patients in and after the ICU. So we have two excellent speakers who will allude to the current issues. We will have the two talks of about 25 minutes for each, and thereafter, at the end, we will have a general discussion with the speakers on the podium. So the first speaker, I'm really happy to introduce my good friend, Professor Arthur van Zanten from Ede in the Netherlands, and will just give us a taste on calories, proteins, early, late, trophic, full. Do we have the answers for the ICU? Please let us know, Hart.
Thank you very much, Jean-Charles. Yeah, it's a challenging topic I would like to address in 25 minutes. Let's see what I can do. Here you see my disclosures. I'm very involved in the field of clinical nutrition in ICU and post-ICU and also in sepsis. So I'd like to address a few topics: the energy and outcomes in ICU patients, proteins and outcomes in ICU patients, and why do we see divergent results in various studies published recently, and maybe some clues or ideas on the next steps towards personalized target nutrition therapy, and some take-home messages. So first of all, it's important to consider when we talk about outcomes that also the pre-morbid condition and the acute illness plays a major role in the final outcome of our patients. And then in the ICU, we give nutrition therapy in the context of inflammatory response, insulin resistance, and all kind of catabolic events. So it's not feeding as in the normal healthy situation that we have to consider always. And then we have the recovery phase and what happens in the recovery phase with respect to nutrition and exercise. And then finally, of course, we have the final outcome of the patient. So it's difficult to pick out one element and to know exactly what is the effect on outcome. So first topic to address, energy and outcomes. What the RCTs tell us and what do the guidelines tell us? Now, there are many observational studies, but there are only a few large randomized controlled trials addressing energy. And this one is by Yassine Arabi, published in the New England Journal of Medicine, 2015, permissive underfeeding versus full feeding. So there was a limitation in caloric intake in one group, and there was no difference in protein intake, and it was due to the fact that in the low energy intake group, they used protein supplements to supplement this and to have an even protein intake. So only a difference in energy here, but there was no difference in outcome. So you could conclude it doesn't matter how much energy you give. And there's another study from the Target Investigators group from Australia and New Zealand that energy dense versus normal energy enteral nutrition with 7.5 kcals per kg per day more intake did not translate into any differences in outcome, and also not in any of the analyzed subgroups. So there is no issue with energy then. It doesn't matter. That's what the RCTs tell us. But there is observational data showing that we have this U-shaped relationship between energy intake in the first week and outcome. So if you give very low energy intake, we see increased mortality. But when you overfeed your patients, you also see increased mortality. And the optimum in the first week is around 70 to 80%. And I think one of the reasons is the endogenous production of energy. During a catabolic state, our tissues are broken down, so we have glycogen in the liver is providing new glucose to the patient, and this process is not stopped by giving nutrition or insulin. So at the moment you are eating now, your insulin levels will go up and you will stop breaking down glycogen and fat from your tissues. You will build it up. That's why we also have obesity. But it doesn't happen in critical illness during the catabolic response in the early days. So what happens if you give the full dose of intake in the first few days? This will lead to overfeeding. And overfeeding more than 110% leads already to increased morbidity and mortality. So what we have to do, we have to adjust the nutritional intake and to give only a little bit of intake on top of the endogenous production, and then gradually over time, progressively, we can increase the energy intake to the patient. And well, this also leads to an average of around 70 to 80% over the first week. So probably this average is due to the fact that in the early phase we have to limit intake, and in the later phase we can go to the full target. And this has also consequences for indirect calorimetry. So this is what we do in our ICU. We make steps of 25% per day until we meet the target on day 4. And then we do indirect calorimetry on day 3 or 4, and then we have the new target because we know the equations are very inaccurate. So some of the equations over and underestimate the real resting energy expenditure by 50%. So you cannot use the equations. We only use the equations for the first 3-4 days, and then we readjust based on indirect calorimetry. That's also in the guidelines. And if you don't have this or the VCO2 method, that's another method by the ventilator times 8.2. That's an estimate of resting energy expenditure. If you don't have it, go to an equation. Okay, so if you don't have it, go for a little bit lower intake during the first week, so 70%. So prevent overfeeding is what we recommend to do then. Now, let's move to proteins and outcomes. What do observational studies and RCTs and guidelines tell us here? Now, first of all, we have to consider the moment you immobilize a patient and there is severe inflammation, like in all ICU patients, this will lead to a loss of muscle mass, protein breakdown. This leads to this problem of severe muscle mass loss. If you've seen this slide before, I think. Zoran Puducherry showed that in the first 10 days of ICU stay that you can lose up to 25% of your lean mass, and that translates into 1 kilogram per day. So that's huge. And we also know that when we provide more proteins, and this is a very old study by Ishibashi, when you increase the protein intake from 1.1 to 1.5 grams per kg per day, this can mitigate or reduce the loss of muscle mass. So that's important to notice that proteins have this effect, probably not by reducing catabolism, but by providing substrate for protein synthesis. And recently we published this study, the protein event study, on the effect of high protein intake in the early phase of critical illness. And we found this in patients with a low intake in the first 3 days of ICU admission, we saw a low 6-month mortality. When the protein intake was very high, we saw an increased mortality. But this effect changed after 3-4 days. And then we saw the opposite. Then high protein intake was beneficial and a low protein intake showed higher mortality. So there is a timing effect of proteins in the early phase, like it is with energy. And if you make groups of this, patients with a protein intake of less than 0.8 8 grams per kg per day on every day during the first week have the worst outcome, so the highest mortality. If it's always above 0.8, it's better. But the best is when you gradually progress from a low intake during the first 3 days to a high intake in the second part of the first week. So there is a timing effect. And this is also in the guidelines. We recommend to give at least 1.3 grams per kg protein equivalents per day, but delivered progressively, also meaning you have to build up to the target. So, and then it's more easy. Now we can use just normal tube feeding or parenteral nutrition by giving it in steps like we do in our unit by 25% per day, both for proteins and for calories. But let's look at the literature for proteins. This is a meta-analysis by Darren Halen's group showing that a higher protein intake of almost half a gram per kg per day with similar energy delivery between groups, started within 3 days of ICU admission and lasting for 3 to 28 days in the ICU, was not associated with a significant effect on these outcomes: mortality, length of stay, duration of ventilation. So again, you could say, doesn't matter how much proteins you give, doesn't matter how much energy, but is it really true? And then we have this recent study by Darren Halen's group, the EFFORT trial, published in The Lancet. And they tried to give a high protein dose in the high group, 2.2 grams per kg per day, and they achieved 1.6. In the usual care group, they aimed for 1.2 grams, and they achieved 0.9. The energy intake was a little bit low, 14 to 13 kcals per kg per day. And you see here that on day 2 already there was a very high protein intake in this high protein group, so around 1.8 grams. I think that's rather high for the early phase of critical illness, but they did it. And what they found, the primary endpoint, the time to discharge alive from hospital by the treatment groups at day 60, there was no difference in outcome. However, in the high protein intake group, they found that the patients with AKI, stage 1 to 3, and SOFA scores above 9, they found increased mortality by the high protein intake, suggesting that those patients metabolically cannot handle a high protein intake dose. Now, we have 2 ongoing studies at this moment. In Australia and New Zealand, the protein target nutrition study with isocaloric high protein versus isocaloric very high protein enteral nutrition. And the endpoint there is mortality. This study is ongoing. And in the Netherlands and Belgium, we do the PRECISE clinical trial, also with the same product, so very high protein intake versus normal high protein intake. And the endpoint in this Belgium-Netherlands study is functional outcomes and quality of life. So a little bit different endpoints here. The PRECISE study will have probably the last inclusion in the next few months, and we will finalize the study at the end of this year. So we hope to present the data next year during this congress. At least in the PRECISE study, we use a gradual progressive intake of energy and protein. So maybe that can be a difference to the EFFORT trial. We have to see. Why do we see these divergent results in the studies? Well, you could say, does it matter at all? Permissive underfeeding is equal to full feeding, high protein is equal to normal protein, but overfeeding may induce harm. Early high protein intake may induce harm, and high proteins in AKI and high SOFA scores may induce harm. And I quoted Albert Einstein here: if you can't explain it simply, you don't understand it well enough. And I think that's the case here, because we look at a very complex system, metabolism. So first of all, some of the patients in our ICU, if not all, have functional problems with the mitochondria. There can be dysfunction of mitochondria in muscles, and the moment this happens, when the ATP production is low in cells, this leads to proteostatic signals to the nucleus. In other words, when there is no energy, protein synthesis will go down. So what happens if we give macronutrients or proteins, amino acids, to a patient who is not able to handle this from a metabolic perspective? Furthermore, the group of Carol Braunschweig suggested this. So in normal situations, when we give exogenous substrates, so nutrition, this will lead to ATP production in the mitochondria, and there will be a little bit of reactive oxygen species. But we have these systems, these complex systems, to handle ROS. But what happens when the mitochondria fail? We will see an upregulation of this reactive oxygen species production, and the defense mechanisms are failing a little bit more. So then we have, well, an abundance of pro-oxidative status, and this can damage cells, tissues, and lead to worse outcome. Also, the group from Geet van den Bergen showed that in the early phase of critical illness, when we give more amino acids to patients in the context of glucagon, and this is really strange to observe, we give patients nutrition, we give them insulin, and still they can have high glucagon levels. That's due to the catabolic response. What they found, when you give more proteins, you see more hepatic amino acid breakdown. So maybe in this phase, it's not beneficial for the patient. And from this, the same study from Zudin Putticheri, it was found they took biopsies on day 1 and day 7 in those patient group with the high muscle mass loss of 25%. And you can see on day 7 there is this inflammatory response in the muscles. It's a little bit small for you to see here. You see the leukocytes. So there is kind of myositis going on. It's very functional for 1 or 2 days because we need the amino acids for the acute phase proteins. So the acute phase response is very beneficial, but probably not when it continues for 3 weeks or so. Now, what he also found, and not everybody has read this in the paper, the unexpectedly higher protein delivery in the first week was associated with greater muscle wasting. It's probably not what you would expect, but maybe it's due to the metabolic condition of these patients. Then we have the EAT ICU study, early goal-directed nutrition versus standard of care from Denmark, an excellent study, and they compared a more aggressive approach of high protein intake and high caloric intake in the early phase compared to a more conventional or usual group. And there was a huge difference in protein and energy intake, as you can see in this slide. But maybe in the initial phase, in the first few days, the protein and energy intake was a little bit too high because we know that it can be harmful in this phase. What they found was no difference in outcome, but they found, and they calculated from urea and nitrogen excretion, that most of the proteins that were given in this enhanced protein group, the more aggressive energy and protein group, was discarded or oxidized into blood urea nitrogen. So it was not used for protein synthesis, but it was just used for energy, like discarded as blood urea nitrogen. And in this large international database analysis, they found that not early high protein intake was beneficial, but late protein intake was beneficial. So this leads to the idea that maybe when inflammation is resolving and metabolism can handle substrate, then it's beneficial to give a little bit more. And it is also, well, it holds also for energy probably. If you have a big meal now, you probably will not die in the next 7 to 12 days. But ICU days which are overfed in the initial phase have higher mortality. So these effects are probably larger in the context of disturbed metabolism. And then we had this large study by Darren Hayland on glutamine and antioxidants, mainly selenium, in critically ill patients. You remember this study, the REDOX trial from 2013, and they found there was increased mortality in the glutamine group. You must have heard about this. And recently, by the group of Zudin Putticheri, they did a reanalysis of this study based on the original data. But now they introduced the concept of urea to creatinine ratio. And what is that? That's the plasma blood urea nitrogen divided by the plasma creatinine. There's a typical ratio for that. And of course, there are confounders like dehydration or blood in the gastrointestinal tract, but typically it can be a reflection of metabolic response to proteins. So if you not can handle the proteins, then urea levels go up. And when you can use it for protein synthesis, it stays in the normal ratio. So they make these quartiles, and they found that the outcomes of the patients were much worse when they have a high UCR, when the ratio was high. And then they did a mediator-moderator analysis, and, well, there was this increased effect of mortality of glutamine and 30 days mortality. But when in the model this UCR was introduced, this effect was gone. And the only effect that was found, that a high urea to creatinine ratio was associated with increased mortality, suggesting that probably it's not the glutamine per se, but it's just a higher protein dose that, well, did harm in patients who metabolically cannot handle the protein intake. So that's interesting to see that even such large studies lead to different insights now. So I think it's all a matter of timing and dosing. So in one patient, energy and protein can be too much. In another, it can be okay to do this. But then we need some kind of metabolic biomarkers to know where we are with our patients and what we can do. For energy, we have some indications that indirect calorimetry can be helpful. This is a meta-analysis of all the studies where nutrition was guided by indirect calorimetry, showing a better outcome of the patients and a reduction in mortality. And, well, we can discuss this whether it's really true, but it's probably helpful to guide your nutrition therapy by indirect calorimetry because it leads to an individual approach. And we know that it goes up and it goes down in individual patients, and you can follow with your nutrition therapy. I'm a believer, and one of my PhD candidates wrote an excellent overview if you don't want to learn a little bit more about indirect calorimetry. And we published this study on that we have to gradually increase over time. And this is valid with all the new data available. So in the early phase, go slow, probably not too much energy, not too much proteins, but when the patient is after a few days and is recovering, you need high protein and high energy intake. We do some work with bioimpedance assessment, and that's difficult because the enemy of BIA is probably water and edema, but you can adjust for that. We have techniques for that to adjust the lean body mass for that because otherwise it's overestimated. And we did a study in COVID-19 patients, and here you see the results. On the x-axis you see the actual total body weight of the patients, and on the y-axis you see the lean body mass of the patients. You see that for males and females, we see different averages. That's no news for you, I think. But many of our equations for protein delivery are based on actual body weight and not adjusted for sex. So that's probably not true. I made an example here also of a male of 100 kilograms of total body weight can have, like here, above 50 kilograms of lean body mass or 80 kilograms of lean body mass. So what about the protein dose? Protein dose is probably associated or needed for the lean body mass, for the muscle mass. So what about giving them exactly the same protein dose? For one, it's too much, and for one, it's a too low dose of proteins. So I think we have to individualize, probably based on the lean body mass of our patient, but then we have to measure it. We recently finalized this study, and we're working on the data, but it shows that when you take the lean body mass and you take the protein dose achieved in the patients, it can be below 80%, between 80 and 19, and 90 to 100% or higher. And what we see here, that over time, the loss in lean body mass is much lower in the patients with the high protein intake. So the patients with the low intake, below 80%, had 13 kilograms of muscle mass loss, while the patients with more than 19% didn't have significant muscle mass loss over time. And we calculate that probably the individual protein target should be 1.83 grams per kg fat-free mass per day. So that's more physiological to base your protein dosing on the muscle mass of your patients and to individualize here. And this is just a single patient to show you the metabolic challenges of our patients. So this is a patient for a long time in the ICU, I think over 30 days or so. And you see the creatinine levels go down. That's due to the loss of the muscle mass over time. That's what you see in your ICU also. You see there were 3 episodes of infection. Increase in CRP, C-reactive protein, due to bacterial infections, Lyme sepsis, pneumonia, something like that. But you see that the daily intake of proteins, this is an hourly protein intake we have in the computer, so the daily intake was almost the same every day. But you see that the UCR, the urea creatinine ratio, goes up immediately after a spike in CRP, and it persists for 10 to 14 days after every event, suggesting that the moment the patient is inflammatory or has problems with his metabolic condition, that you cannot handle the proteins and probably also not the energy. So we have to study this. I come to my take-home messages. Nutrition therapy is a pivotal component of medical treatment in the ICU. Energy and outcomes in ICU, I think slightly underfeeding is no problem, but prevent overfeeding. Proteins and outcomes, after the initial phase, important to mitigate the loss in muscle mass. So then you have to go to a higher protein intake and maybe be careful with the patient with AKI. Why do we see divergent results? Patients have varying metabolic conditions and may not be able to metabolically handle substrate, and this may lead to adverse effects. The next steps toward personalized nutrition therapy are indirect calorimetry to target energy in your individual patients, protein dosing based on the lean body mass, maybe use the urea creatinine ratio as a biomarker of anabolic signaling for proteins, and progressive nutrition therapy during all phases of the patient journey is essential. And also, I've discussed in other sessions, post-ICU, we have to follow up our patients with a better intake. With that, I'd like to conclude, and thank you for your attention.
So thank you very much, Hart, for this excellent presentation. I'd like to invite the next speaker, and then we will have the discussion thereafter. So it's my pleasure to introduce Juan Ochoa, who comes from the US. He is now ICU Medical Director at the Hunterton Medical Center. He is also a surgeon by training, fellow of the American College of Surgeons, and fellow of the ISICEM, and as well as a honorary professor. The challenge for him will be to convince us of the safety and benefits of increasing protein delivery in the ICU. Please, Juan.
Thank you, Professor. So I have worked mostly at University Hospitals, University of Pittsburgh, where I did my training and stayed there as a professor. Right now I'm in the process of trying to wind down and work in my vineyard, and I work in a small community hospital. And one of the things is the lessons that I have learned in this community hospital, which is where the reality of providing adequate nutrition support really meets the road. It's where I have to work with people that, while very interested in providing care, are not interested in being very scientific about it. So I'm going to really focus on, and here's my disclosures. I was a former chief medical officer for Nestle. I don't have any relationships at this point with Nestle, other than I still give lectures like this lecture today for educational purposes. So the challenge right now is, how do we marry the guidelines that are changing in the new paradigm? And I will stress there's a new paradigm in nutrition that is a reflection of a new philosophy in nutrition and critical care, with practical aspects of how we do nutrition support on a day-to-day basis. And one of the things that is fascinating is, and we saw it this morning in the introductory lectures, everybody talks about equivalency studies, and they did studies in pharmacology and looking at different pharmacological agents, but nobody talks about equivalency studies in nutrition, and we'll look at those in this lecture. We've already said that if we follow, by the way, on what is called process management and follow the journey of the patient through their stay coming from home to returning home, there is an episode of a crisis in nutritional intake that generally happens when the patient goes to the hospital, and more when the patient is admitted to the ICU, where the amount of nutrition that the patient can volitionally intake is reduced quite dramatically in our patients. Now, we see what is supposedly a gradual increase in the first 6 to 10 days, which is the average length of stay in an ICU in nutritional intake. But we fall into this gap, and that's been worked, and there's ongoing trials by Arthur Van Santen and Van der Waal and others around the globe saying what happens afterwards, which is really important. And I unfortunately will only mention that in one of my last slides because I will concentrate on how our paradigms have changed in the first 7 days and how important that is. Now, we know from work by Jean-Louis Vincent and by John Kellum in the United States that there are real different phases in the intensive care unit, and that we have to really pay attention at real many issues in the ICU. So we have to resuscitate the patient in the first 24, 48 hours, and then we optimize care. And in that, we have to fit nutrition and medical nutrition therapy. So for ages, and since 1968, since we human beings were able, thanks to Stan Dudrick and others, able to give nutrition by parenteral nutrition, we had this idea that nutrition support and medical nutrition therapy was something that we would do to avoid a caloric deficit, and that a caloric deficit and that decrease in nutrition intake was pathologic. And therefore, that we had to intervene because it was the caloric deficit that produced the disease-related malnutrition in our patients. And so the whole idea and the whole paradigm in nutrition for 50 years was, up until recently, the idea that nutrition support is a food substitution therapy. And so, and there was this concept that food probably is not going to cause that much harm, so let's just do it, and let's, again, avoid this caloric deficit and substitute really early on food intake. And this is very well characterized in one of the trials, which is the EPANIC trial, and demonstrating that you could indeed give more calories and protein through parenteral nutrition supplementation in patients and avoid that caloric deficit. And lo and behold, the demonstration was that there was actually some harm. Now, you can criticize any of these studies by going into them, but the truth is that after multiple studies that one way or another test the idea of the food substitution paradigm, that is avoiding a caloric deficit, that there is either no benefit or the potential for harm in providing aggressive early nutrition support to avoid a caloric deficit. As those trials were being done, and as we focused on calories, and the focus on calories is of historic interest, and I won't get too much into that, but nutrition, clinical nutrition, has focused on calories because population nutrition has focused on calories. That is, how do we feed millions of people around the globe, and how do we prevent starvation around the globe? And so we focused on calories there. And the whole idea is, if you feed 70% of the calories, you're going to be okay. You're going to be okay. We started also to get signals that when we feed only about 50 grams of protein, which is what the average person gets in an ICU currently when you're not doing quality improvement measures, that seemed to be not sufficient, that we had to increase protein intake to about 1.3 grams per kilogram per day. Now, that did not tell us when and what about the timing. Should we do protein substitution and avoid a nitrogen deficit early on or not? And these studies now have been quite clear, and coming with this trial that was shown by Arthur, because it's from his group, showing that feeding too little protein is bad, feeding too much protein early is bad, and just a gradual rise, a gradual increase in protein intake is what we need to do. And so suffice it to say that today in the studies in the Nutri-UI trial just suggests the same thing. We need to be lower. We cannot and we should not be meeting caloric nor nitrogen goals early on in the ICU. That is, the starvation of illness is a physiologic event up to a point. When that point is, we still have to determine that. But let's say that at this point, the best guess without individualizing patient care, and I will emphasize that it needs to be individualized, is somewhere around 7 days. And that you should, by that point, say the starvation response, the physiologic starvation response is either over or the compensation is just not capable of being maintained. And you know this trial that Arthur demonstrated. Now, the next question for me is a very practical question, and this became, for me, a big problem with COVID when I had 170 patients in the ICUs at one night. And I was having the head of orthopedics be my intern. Now, being an intern in surgery is good, but being an orthopedic surgeon, being your intern, is even worse. And so I had to make it so that we made it simple. And roughly, we have 3 generations of enteral nutrition products. The first generation, which is the generation that we would call the standard formulas, give us about 15 to 20% protein, a little bit less than 20%, about 16 to 18% protein. These formulas come historically from what were called the starvation experiments and the castaway experiments done during the Second World War and taken to us as the population experiments. These formulas are based on saying if we give a ton of carbohydrates, a lot of carbohydrates, about 50% or more of the calories, we can minimize the amount of protein because protein is expensive. And so that's what these standard formulas do. A second generation, increase protein, but maintain calories. And so we call them high protein isocaloric. And then in the last 5 to 10 years, as the studies were coming and demonstrating that we were probably feeding too many calories initially, there is a final generation or a generation that has come with very high protein energy restricted diets. They're not all equivalent, by the way. They come from different companies. They're not equivalent. Some have higher carbohydrates, some have lower carbohydrates, some have more lipids, some have less lipids. And so I cannot show equivalency studies between these, but I'll show you some data that compares the 3 different different data, different formulas. So if I have to say my bias, and I have to show my bias, and I'm going to use this example. I'm going to eventually feed a patient 1.3 grams per kilogram per day of protein by 7 days, and I am going to try to achieve that goal. One of my biases now, and one of my changes now in my daily practice is I do not allow my dietitians to calculate nutrition intake based on calories, because we already showed that calories don't matter. And so I focus on protein. So this is our goal. And we're going to try to achieve 1.3 grams per kilogram per day ideal body weight. If I use a traditional standard formula, I will end up giving to that patient a huge amount of sugar. And remember, all of these enteral nutrition formulas, with minimal exceptions, use simple sugars. Do not use complex carbohydrates. And so that's important. I'm going to give 300 grams. That is 7/4 or 75%, almost 3/4 of a pound of sugar in a patient with a standard formula. And I'm going to give an excessive amount of calories. If I use a high protein isocaloric formula, I will probably be around 100% of both. and reach my goals doing that. And by the way, this is calculated, you will give about 20 to 25 kcals per kilogram per day if you do this. And if I give a very high protein energy restricted formula, I'm going to give 70% of the calories, but still meet the 1.3 grams per kilogram per day. And that becomes important. So is this safe? Particularly, so my personal bias is we should never be hitting 170% of caloric goals. And my personal thing is these formulas are of historic interest at this point in the ICU. And so what if we compare, by doing an equivalency study, between high protein isocaloric formulas and very high protein energy restricted formulas. And that's what we did in a prospective randomized open label trial and multi-center trial in 7 studies, with Todd Rice being the principal investigator and I was the senior investigator in this trial. And what we did is we again prospectively compared patients to receive a high protein isocaloric formula with 64 grams of protein and 112 grams of carbohydrates, compared to an experimental formula that received 92 grams of protein and only 76 grams of carbohydrates. And this is important because most studies do not discuss caloric restriction from a point of view of restriction of carbohydrates or restriction of fat or different types of restriction. They just add one thing or another. And it was about the same amount of fat, although there were different types of lipids in these formulas. And what we found, and we looked at the metabolic effects and we looked at safety. What we found, and this is a work by Finfer, is the idea of dispersion. So we used the same principle that Finfer had used of dispersion. And what we found is that indeed the dispersion of glucose levels in patients receiving the experimental very high protein energy restricted formula was significantly less, and we had significantly less hyperglycemias, above 10 millimoles, and seemed to have less hypoglycemias, although we did not have enough data to reach statistical significance. And we did have a mean average decrease about 12 points in blood sugars. So in the world of nutrition, the commercialization of formulas is done without the process that is done in pharmacy. So these formulas could be commercialized and are now commercialized worldwide. When I was at Ochsner Medical Center, one of the things that I did was I implemented a quality improvement measure in our surgical intensive care unit, and this is the change before in the glucose levels before and after we implemented very high protein energy restricted diets as a standard of care. And what you see is a dramatic reduction of almost 28% or 28.5% in hyperglycemias just by changing the diet alone. And the other thing, when we compare to other intensive care units, and there's a little bit of apples and oranges, but what is important is the number of patients that had significant hypoglycemic events decreased significantly because insulin utilization also decreased. So we were seeing at least a more physiologic metabolic benefit of using energy restriction. We also saw other benefits. One of the benefits that was quite dramatic was that in alkaline phosphatase, with a progressive difference between a high protein isocaloric formula and a very high protein energy restricted formula. And what you see is really what you're seeing is fatty acid accumulation in the liver. And so you see a significant increase in fatty acid and fat accumulation in the livers when you give high protein isocaloric formulas compared to very high protein energy restricted formulas. You also see a benefit in minute ventilation with decreased CO2 and obviously a decreased need for bicarbonate compensation by the kidneys. But what also was important in one of the previous lectures, we talked that ketones, allowing some ketones was important. and may be important in the benefit for the patients, is that people that had an energy restriction had measurable ketones in their urine and in their blood. And so there was a statistical increase in ketones, and not surprisingly, there was a significant decrease in white blood cell counts in those patients also by day 7. So we saw at least some metabolic benefits and some suggestion of benefits in this comparison. But what happens in the real world? And in the real world, this is at Geisinger with almost 2,000 patients, 1,899. In the real world, what you see is that about 68% of our patients are overweight or obese. Now, I would say this is the US, but the truth is that this is also worldwide, whether we like it or not. And only 5% of our patients are cachectic. So the idea that we are still working on cachexia is not true. 95% of our patients have other metabolic requirements and come with a metabolic history that is very different. Now, some of these patients undoubtedly have sarcopenia, and that's important to look. But we were able to retrospectively compare intake between the different formulas, again, focusing not on isolated macro or micronutrients, but the formulas themselves. And we compare them between those that receive the standard formula, a high protein, and a very high protein energy restricted formula. And what you see is that the number of calories are generally the same because are statistically the same because patients end up receiving dextrose and propofol as part of their therapies and their other treatments. But that protein intake is gradually increased, and that naturally we're not following the guidelines or the previous guidelines where we were trying to prevent a caloric deficit, but that naturally it seems people are going and slowly, gradually increase protein. However, having said that, when you have a standard diet compared to a very high protein diet, by the end of 7 days, you get about a 40-gram difference in protein intake per day, and you meet protein goals of 1.1, 1.3 grams per kilogram per day in those patients. So it's interesting that there's that difference. We did a multivariable analysis, and we looked again at safety, but as importantly, we looked at, is there a marker that we could potentially use for a prospective randomized trial? And what we found at 30 days is that there was a proportional decrease in mortality that was, again, proportional to the amount of protein intake. So the more protein, the lower the mortality. Now, I will caution everybody, this association is not causality. And that becomes really important. This is merely an association. But it tells us at least that we did not see any signals of harm. And it also tells me that if we're going to use a primary endpoint in a prospective trial, 28, 30-day mortality is not a bad endpoint to do in these studies. And so, again, I have to sit there and say, how do I simplify this process so that anybody, and I use my orthopedics attending, can give nutrition. Now, thankfully, we don't have that problem, and now I'm back to baseline, but still, my other colleagues are not as motivated as I am to calculate every little detail in nutrition. So what do I do? And this is an example. So I do this gradual increase. And what is important is that if I want to meet a little bit of protein, I give the patients just 10 to 12, 10 to 15 milliliters per hour in my patient that are a very high protein energy restricted formula. And I do individualize it, and there's some patients that I won't do this. I increase it to 25 milliliters an hour by day 3 to 5 or 4 to 6, something like that. And then after day 7, I go to about 45 milliliters an hour. This simplifies the entire process. I don't need to do anything more. So from the point of view of simplifying nutrition therapy, this becomes really easy and is easily applicable. What happens after the 7 days? And I'm going to say it, this is what I do, and I want to caution there's still a lot of work to be done after 7 days. And so if I have a patient that is morbidly obese, I cannot ignore that they're morbidly obese. I cannot ignore that. In fact, I have a patient that I left on Sunday with a BMI of 82 in respiratory failure because of a BMI of 82. So I have to find a way to feed that patient. And I will continue energy restriction in those patients after day 7. And I will focus on, are they receiving enough or not enough protein? And I do use urea to creatinine ratios quite significantly. And I do think that indirect calorimetry has a big role in these patients after day 7. It helps me a lot. Now, if the patient is, on the other hand, a patient that is normal, I try to hit somewhere around 80 to 100% of their energy goals. And I, again, increase my protein the same way that Arthur does. I am not as aggressive, although I think that we may end up being right at increasing our aggressiveness. And if I have that 5% of my patients with cachexia, in those patients, as I follow those patients, I do increase my energy intake significantly because they are both protein and calorie depleted. So that is what I do in my practice. So in summary, I am going to end with this editorial that I wrote in JAMA as one of the clinical trials came out, saying feed carefully, feed in moderation, start carefully, and then ramp up. And then at some point, really individualize the care, particularly after 7 days, really start thinking, what does this patient really need? And so nutrition in the ICU anymore, and we need to abandon that idea, not anymore is about food substitution. That idea is gone. It's about metabolic care. It's trying to not cause metabolic harm. There is no reason for us to continue to cause metabolic harm in those patients. I want to thank you very much, and we'll take any questions.
So thank you very much also for this very nice overview. So we will indeed have the opportunity to raise questions. Is there anyone in the room who likes to ask a question? Is there a microphone, or otherwise speak loud and tell your name?
Hi, I'm Dr. Chakravarti from India.
Yeah.
I want to ask you, how do you adjust the protein intake based on urea creatinine ratio?
So you're more of an expert than I am.
Oh, actually, we don't do it yet because we don't know exactly what is the threshold, but we are now to do a retrospective study on many patients because we have the data, and we have to find optimals. What we've seen, when you build up the proteins in the first few days, the UCR goes up, but that's normal. The percentage will be discarded. But then when you are in a stable situation, you can try to increase your protein dose, and when it doesn't go up, probably it can be handled metabolically. When you see a rise in the UCR above a certain threshold, but we have to find it in critically ill adults, then maybe you have to reduce the protein intake. And what we noticed, whenever there is an insult, a surgery, inflammation, whatever, it goes up. So it could mean that at that point we have to reduce the protein and maybe also energy intake. Because also this endogenous energy production, what starts on ICU admission, maybe it happens again after a second insult and inflammatory response. We don't have data on that endogenous energy production in late phases, I think.
Yes, please.
So I'll give you that patient with a BMI of 82, which is a real patient. Her creatinine is low, showing to me that she's sarcopenic. Now, fortunately, she has a normal kidney function, and that I can take away. And so what I do is I challenge the patient. And as I increase my protein, if the urea is not climbing, and again, I have to be very careful on fluid management, et cetera, then I continue to challenge the patient. Now, in that case, I'm restricting her calories severely. I'm doing 800 calorie restriction. Non-protein calorie restriction. And one of the things that you see is the dramatic effect that reduction in calories, particularly carbohydrate intake, in these specific patients and morbidly obese patients has on minute ventilation and CO2 production. And they actually start breathing more comfortably, and they actually do better. And the other thing that happens is that their affect improves. And so they start smiling. They want to participate in physical therapy. And I think it's a fertile area for more research.
Maybe I can add one small aspect. Many patients, about 1 out of 5 patients has refeeding syndrome in the first few days of ICU admission, and we know we have to restrict calories in those patients. Sometimes some intensivists believe that we have to supplement proteins then, because you restrict the calories, but you give the proteins. And we published, I think this week in Clinical Nutrition Aspen, that the mortality in refeeding syndrome is driven by the protein intake and not by the carbohydrate intake. So it's a retrospective study, but you can read it. So also be careful with proteins in refeeding syndrome.
So I think that we can summarize that in if there are many beliefs and thoughts and physiological reasoning, sometimes the clinical trials, the prospective clinical trials, do demonstrate the opposite. And that's an issue that was really quite spectacular and dramatic in the field. I may have a question for both of you. We know that proteins are hopefully used to rebuild muscles. How to integrate the intensity of physical activity into the prescription of proteins, and what about bolus proteins after physical exercise? Maybe Juan first.
Yeah, and I think what is important, and I think Arthur alluded a little bit to that, or one of the previous lectures, is pulse of protein intake is anabolic when the patient is metabolically ready. And that becomes really important. Is the patient metabolically ready to receive a challenge of protein and then start building protein? And at that point, adding physical therapy becomes a really, really important thing. Now, we start with early physical therapy, and there's data that suggests that that's good. But what I think really makes a big difference is once we start really a process of challenging the patient, then the hope is that we get a far better anabolic response.
Yeah, maybe a few additions to that. First of all, exercise is a catabolic event. You have to consider that. So don't do it when the patient is in a severe inflammatory status with the severe metabolic disturbance. So in all the studies, you see that the aggressive exercise strategies are only maybe 1, maybe 2 days earlier. And of course, we try to get the patients out of the bed, in the chair, on the ventilator. But to do real exercise is the moment that the sedation has stopped, and it's a late phase of critical illness in most patients. So don't overdo the exercise in that phase. Second, one of my postdocs, Imre Kau with Leanne Chappell from Australia, showed with labeled proteins that the absorption of proteins, so the amino acid absorption after whole protein meals in critical illness on day 4 is normal. And the abundance of amino acids in the blood is also okay after a meal, but then the problem comes, it's not going into the muscle cells. So they took muscle biopsies, so there is what they call anabolic resistance. So in that situation, you can give a lot of proteins, but when it's not transported into the muscle cell, there will be no protein synthesis. It doesn't help. It will lead to oxidation, urea, and probably metabolic problems, especially, of course, in those patients with AKI, because they cannot handle the urea. So I think, yes, exercise is very important. I think these electrostimulation studies in ICU are a little bit disappointing, because those patients who need it the most, with the high SOFA scores, do not respond on the electricity with a contraction. And the only way to have an anabolic signal in the muscle is contraction. So it's not the electricity, it's the response to the electricity. So I think in most patients, in a later phase, you can start exercising. And when it's possible to exercise, you can probably increase the protein dose, because also insulin resistance will resolve when you do exercise. So I'm a believer in the combination of nutrition and exercise, but I think we have not to do too much in the early phase of hyperinflammation in the ICU.
I think that time is running, so it's almost time to close the session. I would like just to finish with a suggestion or consideration which can be seen as maybe philosophical, or I think that we should distinguish between the safety outcomes with nutrition, which are the complications, maybe life-threatening complications. So an increased mortality would be a safety issue, while the efficacy, we need to be humble. And if we can improve something with nutrition, it should rather be muscle function, functional autonomy, maybe immune response, but should not expect to save lives with appropriate nutrition. But just to integrate nutrition and well conceived, well designed and personalized nutrition in our care plans. With that, thank you very much. Thank you again for Nestlé for having sponsored this session, and enjoy your time in Brussels. Thank you.